Hello friends, I am Shivani Raikwar. Today we are going to deal with an interesting and learning episode of B.Pharm on the important title Antispasmodic, Antiulcer drugs and Antiparkinson's drug. Expert of today's topic is Dr. Ankur Vaidya, Assistant Professor from Pharmacy College, UP UMS, Saifai, Etawah, Uttar Pradesh. So let's start our episode while taking a look at what we are going to learn today. We will begin with the general introduction of the topic, followed by the drugs used for the treatment of the diseases. The lecture has been divided into 5 modules. Module 1, Antispasmodic. Module 2, Anti-ulcer drugs. Module 3, Cyclopentolate. Module 4, Antiparkinson's drug. Module 5, Apomorphine. Now let's start with the introduction of today's lecture. Skeletal muscle relaxants are prescribed for musculoskeletal conditions including low back pain, neck pain, fibromyalgia, tension, headaches and myofascial pain syndrome. The goals of treatment include managing muscle pain and improving functional status so the patient can return to work or resume previous activities. Skeletal muscle relaxants are divided into 2 categories. Antispastic, that is for conditions such as cerebral palsy and multiple sclerosis, and antispasmodic agents for musculoskeletal conditions. Module 1, Antispasmodics. Antispasmodics are the drugs to relax the smooth muscles of the gut. These agents are used to treat indigestion not associated with peptic ulcers, irritable bowel syndrome and of diverticular diseases. Broadly, the anticholinergics or antispasmodics are used to relieve cramps or spasm of the stomach, intestine and bladder. Some are used together with antacids or other medications to treat peptic ulcer. Anticholinergics or antispasmodics are also used in certain surgical and emergency procedures. In surgery, anticholinergics are given by injection before anesthesia to help relax and decrease secretions of saliva and bronchi. During anesthesia and surgery, atropine, glycopyrrolate, hyoscyamine and scopolamine are used to help keep the heartbeat normal. Atropine is also injected to help relax the stomach and intestine for certain types of endoscopic examinations. History and the use of antispasmodics. The first treatment of Shula appears in the Charak Samhita and Sushruta Samhita. Various herbs have been identified and used as antispasmodics. One of them is Apium graveolens. Second is peppermint, that is also known as Mentha pipirata, which is used in the treatment of colic, indigestion, irritable bowel syndrome and flatulence. Ginger roots are also used for motion and morning sickness. It reduces intestinal cramping associated with gastrointestinal infections and functional motility disorders. Antispasmodics can be classified in 3 major subclasses. First, anticholinergics and antimuscarinic agents. The examples include dicyclomine hydrochloride, hyoscyamine sulfate, simitropium bromide, otilanium bromide, octilonium bromide, prifinium bromide and derifenacin. Second, smooth muscle relaxants. Examples include mebavirin, papaverine-like agents. Third, calcium channel blockers. Examples include pyruvarium bromide, etc. Generally, these agents have mixed pharmacological properties. They reduce pain through inhibition of contractile pathways in the muscle wall. The anticholinergic effects on the digestive tract are known to decrease of motility, increase of sphincter tonus and decrease the intestinal secretions. In the United States, the antispasmodic, dicyclomine and hyoscyamine are available for inflammatory bowel disease. Semitropium bromide is a muscarinic compound with strong antispasmodic activity. Among antispasmodic agents, carisoprodol, which is also known as soma, cyclobenzaprine, which is also known as flaxurin, metaxalone, also known as calaxin, and methocarbamol, also known as robaxin, were among the top 200 drugs dispensed in the United States in 2006. Despite their popularity, skeletal muscle relaxants should not be the primary drug class of choice for musculoskeletal conditions. The table which has been shown on screen shows the skeletal muscle relaxants or the antispasmodic agents. Carisoprodol, which is also known as soma, the recommended dosage is 350 mg 4 times daily, not recommended for children younger than 12 years. And most common adverse effects are dizziness, drowsiness, headache, rare idiosyncratic reactions, mental status change, transient quadriplegia, and temporary loss of vision. After first dose may require hospitalization. Allergy type reactions may occur after the first to fourth dose, may be mild, example cutaneous rash, or more severe, example asthma attack, angioneuronic edema, hypotension or anaphylactic shock. Antihistamines, epinephrine or corticosteroids may be needed. Chlorzoxazone recommended dosage is 250 mg to 750 mg 3 to 4 times daily. In children, 125 to 500 mg 3 to 4 times daily or 20 mg per kg daily in 3 or 4 divided doses. Adverse effects include dizziness, drowsiness, red or orange urine, gastrointestinal irritation and rare GI bleeding, hepatotoxicity, discontinue with elevated liver function test. Cyclobenzaprine recommended dosage is 5 mg 3 times daily, may increase to 10 mg 3 times daily. Most common adverse effects are anticholinergic effect, which includes drowsiness, dry mouth, urinary retention, increased intraocular pressure. Rare but serious adverse effects are arrhythmia, seizures and myocardial infarction. Diazepam recommended dosage in adults is 2 to 10 mg 3 to 4 times daily and in children 0.12 to 0.80 mg per kg daily in 3 or 4 divided doses. Adverse effects include dizziness, drowsiness, confusion and abuse potential. Metaxalone recommended dosage is 800 mg 3 to 4 times daily and not recommended in children younger than 12 years. Adverse effects includes drowsiness, dizziness, headache, nervousness, leukopenia or hemolytic anemia, which is rare, liver function, test elevation, which is also rare, nausea, vomiting, diarrhea and paradoxal muscle cramps. Methocarbamol recommended dosage is 1500 mg 4 times daily for first 2 to 3 days, followed by 750 mg 4 times daily. Adverse effect includes black, brown or green urine possible, mental status impairment, possible exacerbation of myasthenia gravis symptom. Ofenadrine recommended dosage is 100 mg twice daily. Combination products are dosed 3 to 4 times daily. And adverse effects are anticholinergic effect, which includes dry mouth, drowsiness, urinary retention, increased intraocular pressure, aplastic anemia, GI irritation, confusion, tachycardia, hypersensitivity reaction with high doses. Tizanidine recommended dosage is 4 mg initially, may increase to 2 to 4 mg every 6 to 8 hours until relief and do not exceed 36 mg daily. Adverse effects include dose-related hypotension, sedation and dry mouth, hepatotoxicity. Monitor liver function test as baseline and 1 or 3 and 6 months. Withdrawal and rebound hypertension may occur in patients. Discontinuing therapy after receiving high doses for long period of time, tapering is recommended. Coming to Module 2, Anti-ulcer drugs. Peptic ulcer is a disease associated with gastrointestinal tract, that is GIT, which is exposed to gastric acid and pepsin. The etiology of peptic ulcer is not clearly known. It results probably due to an imbalance between the aggressive acid, pepsin, bile and H. pylori and the defensive gastric mucus and bicarbonate secretions, prostaglandins, nitric oxide, innate resistance of the mucosal cells. Factors. In gastric ulcer, generally acid secretion is normal or low. In duodenal ulcer, acid secretion is high in half of the patients but normal in the rest. Ulcer is categorized into 3 types. First, gastric ulcer, second, duodenal ulcer and third, marginal ulcer. Classification of anti-ulcer drugs. A number of drugs are available and marketed for the treatment of ulcer. These drugs have different mechanism through they act. The anti-ulcer drugs are categorized in the given lecture. First, reduction of gastric acid secretion. These agents are categorized as H2 antihistamines, which includes cimetidine, ranitidine, famotidine and roxetidine. Second, proton pump inhibitor, which includes omeprazole, lansoprazole, pantoprazole and rabeprazole. Third, anticholinergics, which includes pyrazipine, propantheline, oxyphenonium. Fourth, prostaglandins analogues, which includes misoprostol. Neutralization of gastric acid, which is done by antacid agents. These agents are also categorized as systemic agent, which includes sodium bicarbonate and sodium citrate, and also on non-systemic agents, which includes magnesium hydroxide, magnesium trisilicate, aluminium hydroxide gel and calcium carbonate. Ulcer protectives. These agents are sucralfate, colloidal bismuth subcitrate, which is also known as CBS. Anti-Helicobacter pylori drugs. The examples of these drugs are amoxicillin, clarithromycin, metronidazole, tinidazole and tetracyclines. Mode of action of anti-ulcer drugs. Different anti-ulcer drugs act by different mechanisms, but ultimate aim of all the anti-ulcer drug is to neutralize the gastric acids. Usually, anti-ulcer drugs act through binding different receptors like H2 receptors, M receptors and hydrogen potassium ATPase and inhibit the synthesis of hydrochloric acid in parietal cells. Uses of anti-ulcer drugs. Role of drugs in peptic ulcer disease are relief of pain, ulcer healing, prevention of complications, prevention of relapse, gastric ulcer, duodenal ulcer, Zollinger-Ellison syndrome, gastroesophageal reflux disease, which is also called as GERD, stress ulcers and gastritis, prophylaxis of aspiration pneumonia. Antacids. These are usually basic substances which neutralize gastric acid and raise pH of gastric contents. Antacids do not decrease acid production. Rather, agents that raise the antral pH to greater than 4 evoke reflex gastrin release, which results more acid is secreted, especially in patients with hyperacidity and duodenal ulcer. Acid rebound occur and gastric motility is increased. Antacids are of 2 types. First, systemic antacids. Examples are sodium bicarbonate. It is water soluble, acts instantaneously, but the duration of action is short. It is a potent neutralizer. Non-systemic antacids. These are insoluble and poorly absorbed base compounds react in stomach to form the corresponding chloride salt. H2 antagonist. These are the first line drugs for acid peptic disease. 4 H2 antagonists, cimetidine, ranitidine, famotidine and roxetidine are available in India. Many others are marketed elsewhere. Their interaction with H2 receptors has been found to be competitive in case of cimetidine, ranitidine and roxetidine, but competitive and non-competitive in case of famotidine. Cimetidine was the first H2 blocker to be introduced clinically and is described as the prototype, though other H2 blockers are more commonly used now. Proton pump inhibitors, PPIs. Proton pump inhibitors inhibit the final common step in gastric acid secretion and have overtaken H2 blockers for acid peptic disorders. Omeprazole, lansoprazole, pantoprazole, rabeprazole, esomeprazole are commonly used proton pump inhibitors. The only significant pharmacological action of omeprazole is dose-dependent suppression of gastric acid secretion without anticholinergic or H2 blocking action. It is a powerful inhibitor of gastric acid, can totally abolish HCl secretion, both resting as well as that stimulated by food or any of the secretagogues without much effect on pepsin, intrinsic factor, juice volume and gastric motility. Coming to module 3, cyclopentolate. The IUPAC name of cyclopentolate is 2-dimethylamino-ethyl 1-hydroxy-alpha phenyl cyclopentane acetate hydrochloride. Cyclopentolate hydrochloride is usually employed as eye drops to cause cycloplegia and mydriasis. It acts much faster than atropine and possesses a relatively shorter duration of action. Cyclopentolate or sometimes even longer acting antimuscarinic agents such as atropine, scopolamine and homatropine frequently are used to prevent posterior synesthesia formation between the lens and iris margin and to relieve ciliary muscle spasm causes much of the pain associated with anterior uveitis. Cyclopentolate is synthesized by the interaction between the sodium salt of phenylacetic acid and isopropyl magnesium bromide, which results into a doubly charged species known as the Ivanov reagent. This Ivanov reagent on treatment with cyclopentanone affords aldol condensation to yield the corresponding hydroxy acid. The resulting product on being subjected to alkylation with N,2-chloroethyl dimethylamine gives the desired official compound. Propantheline bromide. Propantheline bromide, the IUPAC name is di-isopropyl methyl 2-xanthine 9-yl carbonyl oxy-ethyl ammonium bromide. Propantheline bromide, which is also called as probenthine, is a widely used systemic non-selective muscarinic receptor antagonist. High doses produce the symptoms of ganglionic blockade. Toxic doses block the skeletal neuromuscular junction. Its duration of action is comparable to that of atropine is high. Propantheline bromide is synthesized from orthophenoxybenzoic acid. Orthophenoxybenzoic acid undergoes Friedel-Crafts cyclization in the presence of sodium and alcohol to form dibenzopyrene, which on treatment with butyl lithium gives acid products. The resulting compound first converted to its sodium salt and then treated with 2-di-isopropyl amino-ethyl chloride and further subjected to quaternization with methyl bromide to give the desired official compound. Propantheline bromide is used in the treatment of acute and chronic pancreatitis, pyrolospasm, gastritis and ureteric and biliary spasm. It also finds the application as an adjunct in the treatment of gastric and duodenal ulcer. Benzhexol. Benzhexol is also known as triethoxyphenyl hydrochloride or trihexyphenyl chloride. Its IUPAC name is alpha cyclohexyl alpha phenyl 1 piperidine propanolol hydrochloride. Triethoxyphenyl hydrochloride, which is also known as artane, are tertiary amine muscarinic receptor antagonist that gain access to the CNS and can therefore be used when anticholinergics are indicated to treat Parkinsonian and the extrapyramidal side effects of antipsychotic drugs. It is an antiparkinson drug possessing relatively weaker antispasmodic and antimuscarinic properties. In fact, it is the drug of choice for the treatment of Parkinson's. It is also employed for the relief of echinacea, muscular rigidity, tremor and achillogria. It is also found to be useful in the treatment of drug-induced extrapyramidal symptoms. Benzhexol is prepared by the manic condensation of acetophenone and piperidine with formaldehyde by refluxing the reactants in 60% of ethanol. The resulting product is subjected to Grignard's reaction with cyclohexyl magnesium bromide to yield the corresponding base, which is subsequently precipitated by passing a steam of hydrogen chloride through a solution of the base in a suitable solvent. Coming to Module 4, Antiparkinson's drug. Parkinson's disease, Huntington disease, Alzheimer's disease and amyotrophic lateral sclerosis, which is also called as ALS, are characterized by progressive and irreversible loss of neurons from specific regions of the brain. Parkinson's disease is an extrapyramidal motor disorder characterized by rigidity, tremor and hypokinesia with secondary manifestations like defective posture and gait. Mask-like face and dementia may accompany. The pharmacotherapy of these neurodegenerative disorders is limited mostly to symptomatic treatments that do not alter the course of Parkinson's disease. If untreated, the symptoms progress over several years to end-stage disease in which the patient is rigid, unable to move, unable to breathe properly, surrenders mostly to chest infections, embolisms. Parkinson's disease is a progressive degenerative disorder mostly affecting older people, first described by James Parkinson in 1817. The pathological hallmark of Parkinson's disease is a loss of the pigmented dopaminergic neurons of the substantia nigra that provide dopaminergic innervation to the striatum, also called as caudate and putamen. Progressive loss of dopaminergic neurons is a feature of normal aging. However, symptoms of Parkinson's disease coincide with excessive loss, around 70 to 80% of these neurons. Without treatment, Parkinson's disease progresses over 5 to 10 years to a rigid, akinetic stage in which patients are incapable of caring for themselves. Death frequently results from complications of immobility, including aspiration pneumonia or pulmonary embolism. The availability of effective pharmacological treatment has altered radically the prognosis of Parkinson's disease. In most cases, good functional mobility can be maintained for many years and the life expectancy increase substantially. Several disorders other than Parkinson's disease also may produce Parkinsonism, including some relatively rare neurodegenerative disorder, stroke and intoxication with dopamine receptor antagonist. In Parkinson's disease, an imbalance between dopaminergic or inhibitory and cholinergic excitatory system in the striatum occur, giving rise to the motor defect. Though the cholinergic system is not primarily affected, its suppression by anticholinergics tends to restore balance. Belladonna alkaloids had been empirically used in the treatment of Parkinson's disease. A breakthrough was made in 1967 when levodopa was found to produce dramatic improvement in Parkinson's disease. Its use was based on sound scientific investigations made in the preceding 10 years that dopaminergic is present in the brain. It, along with other monoamines, is depleted by reserpine. The reserpine-induced motor defect is reversed by DOPA, the precursor of dopamine. Stratum of patient dying of Parkinson's disease was deficient in dopamine. Thus, Parkinsonism was characterized as a dopamine deficiency state, and levodopa was used to make good this deficiency because dopamine itself does not cross the blood-brain barrier. In the subsequent years, a number of levodopa potentiators and dopamine agonists have been developed as adjuvants and alternatives. Classification of anti-Parkinson drugs. First, drugs affecting brain dopaminergic system. A dopamine precursors, levodopa, peripheral decarboxylase inhibitors, carbidopa, benzhexol, dopaminergic agonist, bromocriptine, pramipexole, MAO-B inhibitors, salicyline, COMT inhibitors, entacapone and tolcapone, dopamine facilitator, amantadine. Second, drugs affecting brain cholinergic system. Central anticholinergics, trihexyl phenydyl, that is Benzhexol, procyclidine and bipridine. Antihistaminics, ofandrine and promethazine. In addition to drug therapy, which only offers a symptomatic relief, adjunctive therapy for Parkinsonism include physical therapy to delay disability and emotional support to lessen feelings of helplessness and inadequacy in the patient. Some new methods for the treatment of Parkinson's are also under experimentation. Important among them are: first, implantation of adrenal medullary tissue in the brain to provide a source of dopamine, and second, implantation of fetal nigral tissue in the brain to replace the deficient dopamine producing cells of the substantial nigra. Levodopa, a metabolic precursor of dopamine, is most commonly used as anti-Parkinson drug in the treatment of Parkinson's disease. This levodopa penetrates the blood-brain barrier and is converted to dopamine in the brain, thereby replenishing the deficient neurotransmitter. The enzyme DOPA decarboxylase, which converts DOPA to dopamine, is not only present in the brain but also in the plasma as well. As such, a significant fraction of an oral dose of levodopa is converted to dopamine in the plasma and cannot penetrate the blood-brain barrier. Thus, very large amount of levodopa are required to provide clinically effective levels of dopamine in the brain and is associated with many adverse reactions. For this reason, levodopa is seldom used alone today. To overcome this problem, fixed dose combinations of carbidopa and levodopa in the ratio of 1:4 or 1:10 are available. Carbidopa is a peripheral DOPA decarboxylase inhibitor. It competes with the enzyme DOPA decarboxylase, thereby retarding the peripheral breakdown of levodopa. This allows the greater fraction of the levodopa dose to cross the blood-brain barrier, producing higher dopamine level in the central nervous system. Now coming to module 5, apomorphine. Apomorphine, also called as apocrine, is a dopaminergic agonist that can be administered by subcutaneous injection. It has high affinity for D4 receptors, moderate affinity for D2, D3, D5 and adrenergic alpha 1D, alpha 2B and alpha 2C receptors, and low affinity for D1 receptors. Apomorphine is used as a rescue therapy for the acute intermittent treatment of OFF episodes in patients with a fluctuating response to dopaminergic therapy. Apomorphine shares the side effects of the oral dopamine agonist. It is highly emetogenic and requires pre and post-treatment antiemetic therapy, generally oral trimethobenzamide, started 3 days prior to the initial dose of apomorphine and continued at least during the first 2 months of therapy. Based on reports of profound hypotension and loss of consciousness when apomorphine is administered with ondansetron, the concomitant use of apomorphine with antiemetic drugs of the 5-HT3 antagonist class is contraindicated. Other potentially serious side effects of apomorphine include injection site reactions and the development of a pattern of abuse characterized by increasingly frequent dosing leading to hallucinations, dyskinesia and abnormal behavior. Because of these potential adverse effects, use of apomorphine is appropriate only when other measures such as oral dopamine agonist or COMT inhibitors have failed to control the off episodes. Apomorphine therapy should be initiated in a setting where the patient can be monitored carefully, beginning with the 2 mg test dose. If this is tolerated, apomorphine can be titrated slowly up to a maximum dosage of 6 mg. For effective control of symptoms, patients may require 3 or more injections daily. Apomorphine stimulates the CTZ and causes emesis. The drug is unstable in solution and must be prepared just prior to use. Apomorphine is not effective orally and must be given parenterally, usually subcutaneously, 6 mg for adults and 0.06 mg per kg for children. Vomiting ensues in 3 to 5 minutes. Subcutaneous administration can be an advantage with an uncooperative patient. Because apomorphine is a respiratory depressant, it should not be used if the patient has been poisoned by a CNS depressant or if the patient respiration is slow and labored. At present, apomorphine is used rarely as an emetic. Coming to the summary of today's lecture. Antispasmodics are the drugs to relax the smooth muscle of the gut. These agents are used to treat indigestion not associated with peptic ulcers, irritable bowel syndrome and of diverticular disease. Broadly, the anticholinergics, antispasmodics are used to relieve cramps or spasm of the stomach, intestine and bladder. Some are used together with antacids and other medications to treat peptic ulcer. Anti-ulcer agents are substances used to cure ulcerogenic conditions. Usually, 3 types of ulcers exist, namely gastric ulcer, duodenal ulcer and marginal ulcer. A number of antacids, H2 blockers and proton pump inhibitors are commonly used in the treatment of ulcer. Parkinson's disease is a neurodegenerative disease in which dopamine level is depleted in substantia nigra. Now students, you must have understood about the anti-ulcer, antiparkinsons and antispasmodic drugs. We have come to the end of today's lecture. Till then, you keep studying and I am Shivani Raikwar signing off. See you in the next episode. Goodbye.